Hello, everyone. Welcome to the second episode, the round of the webinar series discussion we're calling the Global IR Roundtable. My name is Tariq Al-Hakim, and I'm currently a PGY3 internal medicine resident at Kendall Regional Medical Center in Miami, and will be pursuing a career in interventional radiology afterwards. My co-moderator, Napreet, is currently an intern at IGGMC in India, and will be pursuing an DR-IR residency as well. We're both interested in global health IR and excited to get to moderate this evening discussion as members of the SIR-RFS International Outreach Committee. So in accordance with our mission to provide guidance and resources for students, residents, and fellows interested in global health IR, we have invited an international group of aspiring interventional radiologists to discuss today's important topic about funding opportunities in international IR work. So the format of today's discussion will be an informal roundtable conversation between ourselves and our international panelists. We hope that by providing a space for deeper exploration of topics relevant to global health IR, we can help ourselves to grow in our understanding of current challenges and possible solutions relevant to the field today. Just as a reminder, this episode is a follow-up discussion to our previous episode posted in our YouTube channel, which was titled The Importance of Establishing an Equipment Procurement Network, Challenges and Opportunities, where we discussed the technical challenges of acquiring, implementing, and maintaining a supply chain of medical imaging and disposable IR equipment in resource-limited settings. Our previous aspiring panelists have pointed out great insights about this discussion, including several opportunities and challenges to tackle. Among those is the funding opportunities for general international IR-related work, which will be our today's Global IR Roundtable discussion. As such, make sure you grab a seat and join us in our today's roundtable discussion, where we have guests from all around the world, including USA, Nigeria, and Tanzania. What a diverse roundtable discussion today. So as we all know, that funding is one of the primary limitations of expanding IR services in resource-limited settings. As such, today's discussion will be centered around the process of procurement, utilization, and distribution of funds in global IR work. Hopefully, this webinar will equip everyone with essential information to establish and advance global IR. I just want to point out a few quick housekeeping topics before we get started, please. Let's remember that today's webinar will be recorded and uploaded in the RFS website and YouTube account for future viewing and reference. As well as in our roundtable discussion, we encourage our guest speakers to jump and respond to each other. If you find anything interested to comment on, or if you want to ask any follow-up question, you're welcome to do that as well. So after approximately 45 minutes, we will open the floor for audience questions and comments. Please note that you will not be able to ask your question verbally on our webinar platform, but should instead type your question in the control panel, and we will read them to the panelists during the question and answer discussion portion of our program. As you think of a question during the conversation, please feel free to type it in the control panel, and we will refer to them when we reach to the question and answer portion of the webinar. So we will provide our email address in the chat bar for people reference. Should you have any follow-up question or communication, you can email us over there. So before we get started, we would like to thank Brian Covello and Devan Ramachandran, who are our current RFS communications co-chair, as well as Monica Matsumoto, Aya Mujahid, and Andy Moore from the RFS International Outreach Committee for helping us to facilitate this webinar. I would also want to thank our panelists, Dr. Fabian, Dr. Eric, and Dr. Hamad for sharing their experience and insights with us today, and for joining us and for taking the time to participate in today's important conversation. So I'll hand it to you, Napreet, to start off by introducing our panelists, please.
Thank you, Tariq, for this great introduction. And thank you everyone for participating in our second episode of the Global IR Roundtable discussion. It is a pleasure to host this discussion, and we would like to send our endless appreciation to all of you for joining us today. I would now like to introduce our guest speakers who have kindly agreed to participate with us in today's discussion. I start with Dr. Andrew Kesselman. Dr. Kesselman is an attending interventional radiologist and assistant professor of radiology at the Weill Cornell Medicine and the New York-Presbyterian Hospital. He currently serves as the director of the IR section at the RAD-AID organization, which is a nonprofit that aims to increase and improve radiology and imaging technology in the resource-limited regions and underserved communities of the world. Next, we have with us Dr. Fabian Raggop, who is an interventional radiologist and assistant professor of radiology at the Yale School of Medicine. He's also the co-founder of the Road to IR training program, which aims to build self-sustaining IR training programs, and among which is East Africa's first accredited IR training program established in Tanzania and currently being developed in Rwanda. Road to IR has recently graduated its first 3 fellows on its 2-year IR program at Muhimbili National Hospital in Tanzania. And we are grateful today to have one of those fellows join us, Dr. Eric Muguje. He's an interventional radiologist currently practicing at the Muhimbili National Hospital in Tanzania. He's also a co-founder of the Road to IR training program. And as I mentioned, he's among the first fellow graduates of the Road to IR training program at the Muhimbili National Hospital. We also have with us Dr. Hamid Ninalowo, who is an interventional radiologist practicing in Nigeria. He completed his IR training at the University of Pennsylvania. He's the first US trained physician to offer the full spectrum of IR services in Nigeria through his organization, IRDOCNIGERIA. This organization provides full IR services in Nigeria, and it also aims to build capacity and sustainability in local IR services through partnering with organizations such as RAD-AID to collaborate with teaching universities in developing local teaching and training programs. Unfortunately, Dr. DeepaShree was unable to join us today, but we hope to host her soon in one of our future webinars. So with this introduction, I would like to start today's discussion about the funding opportunities for international IR work. And I will let Dr. Tariq share the first question with our guest speakers. Thank you.
Thank you very much, Navreet. Dr. Kesselman, if you don't mind, we would like to start with you. It would be great if you can share a little bit about your own experience working in the global health IR space, especially as a director of the RAD-AID IR program. Just to conceptualize your perspective, and then in light of that, if you can share your experience with securing funding for expanding IR in the low resource limited setting.
Sure, no problem. So I've worked with RAD-AID for many years now. I've served as director since the IR program started about 4 years back now. I actually did recently, I should mention, I stepped down now. I'm associate director now. I've stepped down from my current role, given my family is now grown, but I still have a lot of experience from what we've done before, so I can definitely speak to that. You know, as a trainee, my role was different than now currently as attending, but we send deployment teams to different sites. So it's usually a team that involves a trainee, an attending, and then sometimes a tech or a nurse as well. And the main avenues for funding that we've looked at are mostly for these deployments to send and support educational efforts in countries. So what we've done is help support our program sites with educational efforts. And a big portion of that was pre-COVID sending deployment teams, and now currently resending deployment teams there. The main funding opportunities that we've looked at that would be pertinent, I guess, to this group of SIR members, trainee members, is the grant opportunity that we have as a partnership with the SIR. So RAD-AID has partnered with the SIR, I think since, let me see how long ago we partnered. I think since 2019. And there's a grant opportunity there. If a SIR trainee member signs up for one of our deployment teams, they'd be able to apply for this grant opportunity, and it provides up to $2,500 of funding towards travel and expenses for that deployment trip. So I think that's the main opportunity that we offer for funding as part of our program for RAD-AID. There are other opportunities for fundings for trainees to also do outreach. The ones I'm aware of that I have experience of others using is there's a Goldberg, the ACR has a Goldberg reader grant that you can obtain as well to fund your project, to do international work. I haven't had experience with that specifically with our IR members, but on our DR side, we definitely have experience of people using that funding. And there's a Doximity grant through the Doximity Foundation that offers funding for your flight for trips. And I know others have used that before. And then finally, some institutions, including the ones I've worked at in the past, offer funding opportunities internally for trainees that want to go and do international work trips on using a GME approved elective. So those are the main opportunities that I'm aware of for funding educational opportunities for trainees to go and do this kind of outreach work.
Thank you, Dr. Kesselman, for sharing your insights. I would like to ask the same question to Dr. Hamid. If you can also share some of your personal experiences in the global IR space and securing funding for expanding IR in such low resource settings, especially in context with your experience in the IRDOCNIGERIA journey and establishing the program.
Can you guys hear me?
Yes.
Yes.
Okay, very good. All right. So interestingly, my journey started with RAD-AID with Andrew and his crew. I guess it started a little before RAD-AID, but mainly I started looking into working in Nigeria and doing interventional radiology work or radiology work in Nigeria. I think in my second year of residency, where I came just to kind of shadow down here, and I actually just self-funded myself and did some preliminary surveys of what was available in the country. And then when we started IR, we started bringing RAD-AID teams to the country, which was most of the physicians and nurses. The physicians were mostly self-funded. The nurses were funded from the nursing organizations. But as far as the story of how we've gone about with our practice, so I started out first in a public institutions here, but I got very frustrated very quickly, and then we went into private practice, and it's not been easy going into private practice because I've had to basically run a business in that I've had to self-fund a lot of the equipment coming into Nigeria. But for me, I thought that was the only way to do it instead of waiting for, a lot of different organizations to help fund us. We've gotten some donations from companies like Medtronic, which we've distributed to the public universities. We've gotten donations from other centers. But what I always emphasize, and I was really hoping the doctor from India was going to be on this seminar. The reason for that is I think they figured out what sustainability is in India, and the way they figured that out is the government has done a lot of intervention with the companies into making the equipment we use very cheap in India. So a catheter in India probably costs 30% of what it costs in the US. And that's because the government has put a cap, on what a company could charge there per catheter or per device. And I think really that's the only way forward. We've been beating the drums for a long time as far as, can we make the equipment cheaper for Africa? For example, getting the equipment from the US and from Europe, and it's just not realistic. I think, if we started thinking about, Africa as a region, and then, started thinking about manufacturing or I think what we really need to be advocating for is the companies manufacturing equipment here in Africa and finding hubs in Africa where we could use African labor. We could use, the labor is cheaper here, obviously, sourcing materials are cheaper here, obviously. And I think that's probably the only way to kind of get things going for cheaper and sustainable going forward. Looking for funding opportunities from the US, that's just unsustainable. Looking for donations is unsustainable. So I really think we need to start advocating for looking for manufacturing hubs here in Africa, and I think that's the only way forward.
Awesome. Thank you very much, Dr. Hamid. As you mentioned, we should always keep advocating about this part. And this was actually something that we pointed in our previous webinar about the equipment procurement and the fact of establishing a major equipment producing companies over there so that to implement this and to make it easier. But yeah, that was a very helpful insight about your experience. Moving on to Dr. Fabian and Dr. Eric, we would like you both to complement each other on your personal experience with the global IR space, especially with your inspiring journey in the Road to IR training program and establishing an IR training pathway in Tanzania. It would be great also if you can also share your personal experience with securing funding for expanding your work.
Hey, I'll just go ahead, and Eric, if you're in and that is good right now, just chime in. So yeah, just really confirming like everything that was already said. There's different funding sources. Some are easier to get than others. This global reader grant, for instance, I think, Andrew, that's just like travel funding basically, right? They just sort of pay a single trip. That's my understanding, but the application looked somewhat involved. So I never had anyone actually do that. But the Doximity fund that Andrew mentioned actually is awesome because it's like very simple. The application is like 10 minutes, and it works for trainees, for IR trainees, for physicians, and for APPs. So it doesn't work for nurses and technologists, unfortunately. It also doesn't work for medical students. But other than that, it's really awesome just because it's so simple to apply for it. And then, of course, we've been funding a lot of trips for medical students, trainees, nurses, techs, faculty, and APPs through RSNA. And our application was basically also very very simple. But the important thing, I think, when doing any sort of global IR work is to have diverse funding sources. So you can't really rely on one source of funding exclusively. So you're going to need to try to mix it up a little bit, and that's what we've been doing in Tanzania. Is that we had this RSNA grant, which was $75,000, which has now been lasting for about 2 years, but we're about to run out this summer. But then we've been trying to supplement with as much Doximity funding as we can, some self-funding, and some other sources, so some institutional funding. And with that, we've been able to sustain it pretty far. Eric, anything you want to add? Maybe his connection's down right now.
Okay, that was great. Thank you, Dr. Fabian. Moving on to the next question, if you guys could shed some light on what was the process you followed in order to obtain funding, and what are the various avenues to consider when allocating these funds? And at this point, anybody could chime in.
Yeah, I can say a word on that. So just how to allocate funds. I think the first question is like, why are we doing this in the first place? Because the alternative is to basically the goal is to train doctors, nurses, and technologists in interventional radiology, right? In places that haven't had IR training until now. So there's two options, right? Either you can bring people to the US and train them there, or you can train people overseas. And the problem with the first option is that it's very time and what's the word? Like financially burdensome, right? So I myself am an IMG. Hamid went through this. Tariq is going through this right now. So it takes a lot of first of all, it takes a lot of work. It also takes money, and then it also takes a good amount of luck, right? So you need your visa to come through. You need to take your USMLEs. You need to get into residency, etc. So of course it's doable, but not at the scale that's needed, right? So in sub-Saharan Africa, there's need for thousands of interventional radiologists to get thousands of people to move to the US for their training, and then to move back there would be very difficult. And the other thing is, what happens is that a lot of people that come to US to train, of course, stay there, myself included, right? Because it's not that I don't like Germany, everyone knows I actually love Germany, but once you move somewhere for your training, you kind of settle down there, right? If my wife in the US, people start having kids, etc. So at some point it gets sort of difficult to move. So I have to really applaud Hamid for moving back to Nigeria, but it's very rare. So then coming back to your question, how should funding be allocated? So I think the way to allocate it is really like our main goal in Tanzania was to get as many people to travel to Tanzania to train the trainees and the nurse and the technologists there. That was really the main goal, to try to run the whole operation as lean as possible and to get as many people there as possible to train them. So that's basically what we've done. We've tried not to waste any money, but really to just invest it in flights and housing and get people there.
And I always kind of admire what Fabian and the Tanzania group has accomplished from afar, because it takes a lot of dedication, right, to be able to put that program together, continue to recruit people to come down to the program, create awareness, make people enthusiastic about wanting to go to that program, and more so, you have to applaud the folks in Tanzania, because it takes a degree of a sense of humility for you to have foreigners come down and show you what to do all the time and absorb all of that knowledge, right? So, and different cultures, and you have to understand different cultures in Africa, anywhere in the world, in order to kind of accomplish training programs. So I'll give you an example. In Nigeria, because I've been so frustrated with training, I offered that I was going to pay for a fellow to come join me and pay salary for 2 years. I made that offer last September, and we did recruit a fellow successfully from a university. And now we have a stumbling block because the university have stopped them from coming. They initially said we would pay for his training, and then they said, well, you have to wait for 2 months, and now it is being stopped from coming until June or July. So that's 6 months wasted. Right. And you would think, if, we're offering training for free, we're going to send this guy back to the university, this would just be absorbed, right? Anyone would jump on this opportunity, but it's just not like that, So I think, especially in, global IR training, you really have to understand the cultures of where you're going. So as I said, from afar, I've really, really admired what they've put in Tanzania, and it's not easy, to continue to, put fire into that program, especially with going through COVID. I mean, that's just amazing what they've done. So I just want to applaud that.
Yeah, there's a lot of politics, like Hamid is saying, like things don't always make sense. Sometimes you have to deal with, egos, and things don't always make sense. And, and obviously there can be setbacks, quite often.
Awesome. Thank you both for this great insight. As you mentioned, it takes a lot of dedication to accomplish something like that, and like great job overall on achieving something like this.
And it's not a coincidence. Eric's nickname is the mayor, right? It's because he's he's the one that manages all of these different egos and make sure that people stay happy everywhere.
That's very true. And when you go to Tanzania, you can see that, and it's being placed as the mayor of Tanzania almost.
Yeah.
All right. Thank you guys for this great insight. Moving on to the next question. Just if you guys don't mind sharing us like some difficulties you encountered during the process of obtaining funding, and how did you tackle this difficulties? If anyone can answer
that. Can you hear me?
Yes, Eric.
Yeah, I was trying to, when the internet was bad, please let me know. I think from the question, I thought you were supposed to ask you what were the simplest things to do, because the whole process was difficult. So we cannot just mention the good stuff, but it's better the difficult stuff, because the entire process has a difficult approach to had a difficult process to pass through. So we can at least mention the easy way or the easy process we encountered, because 90% has like a hassle on it. So the only simple process, for instance, from our side, we had a proper, and we had like 100 commitments from the hospital side. Sometimes you can have people wanting to help you, but the bosses, the nearby bosses, the immediate bosses bring some difficulties, bring some barriers. So the most advantage part, for instance, from Tanzania is like we had a good support from the hospital administrations, and a little bit we had like a good push from the university side, because they worked hard to make sure that our program has been accredited from the National Accreditation Institute. So those are the major two things which were easy for us to pass through. Apart from that, were like the difficult process. Having equipment in Africa, you know, as Hamid was explaining, having like even those equipments to be registered in Africa is a process. The interventional radiology itself to be understandable to our fellow clinicians, it was a difficult process. So I wanted to make it in a reverse way, that this question should be like rephrased to be like, what were the easiest process? Because the entire process was difficult. Can I pass this to another person? Thank you.
No, and I'll just echo what Eric said. You know, I mean, doing IR in Africa, you know, especially if you want to do it on a complex level, you cannot imagine everything you have to put in place. So I just spent 2 weeks in the US for the first time in 2 years, in Florida last month, right? So I worked at this hospital where those were the least stressful 2 weeks of my life in the last, say, 4 years since I've been doing work in Nigeria, right? Because I went to work, you know, I got to work, you know, someone gave me my list for the day. I was in my office, they called me, this patient's ready, I consented, I go back to my office, they call me, the case is ready. I do my case, and I could be pretty efficient. So I do my case, I'm back in the office, you know, and that was my day, you know. Here, you know, I've just gone through with my assistant all day today, what my supply chain is. You know, if we have this catheter or wire for the cases we have in the next week, you know, I'm a supply manager here, I'm a business manager, I'm a doctor, I'm everything, you know. And, you know, that's what it's taken to be able to, you know, provide IR services here. But, you know, it's for me, it's like cocaine though, you know, being able to take care of your own people here at home, being able to do things that are impossible. You know, I kind of just feed off of that. Every time we do a new procedure, like this past week, we did our first sacroplasty. It's a procedure that I did routinely in the US, but we just never done one here. So for me, it's a thrill every time we do those things. And now it's becoming a routine where, you know, people are starting to understand the value of interventional radiology and the process of it. And, you know, what we've done in Africa so far is also opening those opportunities that, you know, Fabian was talking about into. I know it's hard to get a lot of trainees to go to the US, but I got an email from the program director at Harvard, the pediatric IR at Harvard last week, who was asking if I had a trainee who could come over for fellowship for a year and would promise to come back to Nigeria. So we're winning very slowly, you know, but the fact is we're winning, but, you know, every part of it is significantly difficult. And, you know, the people who want to be part of global IR just have to understand that, you know, it's not going to be easy, but it's not impossible.
Yeah, I would like to make a comment that echoes a lot of what they already said. So I agree. I think the consumable constraints in country is very difficult to overcome. And I think there's a lot of frustrations tied to that. And also, I think the biggest part is you're going to have to deal with having to have a lot of patience, because I think Fabian could speak to this too. Just to get the curriculum that we wanted approved in Kenya for the IR fellowship itself took more than a year, and that's having a basis from that to start with. So I think, and you know, to create a sustainable program, you're going to want that you know, that sort of legitimacy to your program. So I think in talking to funding, it's also going to be a lot of, I think, just patience and hard work that's going to go into these things to make those type of things happen.
And there's always going to be ups and downs.
Yeah, for sure. I think, you know, with our program in Kenya, we had a strong push early on, and then COVID hit, and it kind of set us back in terms of the deployments we have. So we had to pivot to a lot of web-based and remote work. And now that we're sending deployments again, I think things are getting back a little bit more to where we were before. But you're just gonna have to work with those kind of changes. And I guess that's also tying into what you said about allocating funding, right? You're gonna see what the opportunities are and where those can be best used to create sustainability. And when things change, you're gonna have to pivot a little bit for those resources too. We do regular readiness assessments at all our sites. We're actually currently doing an update to a readiness assessment in Kenya. So that helps us kind of also distinguish where we want to tie our funding to in terms of our educational efforts there.
Yeah, and so what I'll say is that, in Tanzania, like, and Eric can confirm this, we've had times where, Eric was sort of ready to quit IR just because it was like, too much and, too much uncertainty and too many hurdles. And I've had my times where I was like, screw this, it's not worth it. What are we trying to do? But then you have your moments where you really realize that, it is just needed, like Hamid is saying, anytime you do a procedure that actually makes a difference to a patient, then you get that kick, and, it gives you the drive to sort of keep doing it. And, we've certainly had our tough times in Tanzania. There was a lot of times where really we just didn't know, are we going to get the next round of funding? Is the curriculum going to be approved? Are we going to find enough people to travel during COVID, et cetera, et cetera. But then somehow, sometimes in the last minute, things worked out, and we sort of just kept going.
Thank you. Those were some great points, and you all painted a really nice, realistic picture of what to expect and what difficulties generally come along the way. So based on Dr. Kesselman and Dr. Fabian touched on this topic, how has the pandemic impacted these funding opportunities in global IR work? And if you can talk about that a little bit, and how it is evolving now, seeing that the cases are declining, are you guys opening up your programs, and how is the whole situation turning out to be?
Yeah, so I can get started on that. So honestly, the funding opportunities themselves didn't really change that much, because it's not like any grants were sort of closed due to COVID. But initially, starting in March 2020, the problem was that universities didn't allow travel at all. So we weren't able to do any trips for half a year in 2020, but then we were able to resume our monthly trips to Tanzania in November of 2020, which is relatively early, compared to some other programs. And obviously, at the time, sort of was considered somewhat risky, but we just felt that we didn't really have much options, because Eric and his class were needed to get ready to graduate in September of 2021. Okay, and that was the first class, and the service in Tanzania was already running, but they weren't ready to do procedures themselves yet until graduating. Also from a legal perspective. So we felt that it was really important that we send as many teams to Tanzania as we can to get Eric and his class ready to graduate. So that's what we did. And honestly, we haven't had a single issue, COVID-related issue since then. And we've had 33 faculty in Tanzania after COVID and 14 before COVID. So we've actually had now like more than twice as many after COVID than before COVID. And like I said, not a single COVID-related issue. So everyone can have their own thoughts on sort of COVID precautions and whatnot, but for us it worked out well, despite sort of starting things early.
Well, for me, interestingly, when COVID started, I had to make a decision, because what I was doing was I was spending 6 weeks in Nigeria, 2 weeks in the US consistently before COVID, and I had to make a decision if I would basically have to come back to the US to work or stay in Nigeria, and the decision was to stay in Nigeria. And for me, COVID was actually a very good thing, because it showed me that I could actually survive here. I mean, we had to be deep into getting materials into the country. because I couldn't travel at all because all my supply chain was basically traveling out to the US, coming back to Nigeria to do my work. It showed me that I could actually survive without working in the US for a very long time. However, on the other hand, we had regular RAD-AID trips to Nigeria every 2 months, 2 attendings, 3 nurses go do some work. That completely died. So I was actually going to the universities myself, but I was much less effective than when we had a whole team come in to do the work. So we still haven't restarted those trips from RAD-AID's perspective. We should hopefully restart it before the summer this year. But COVID was both a good and a bad thing. And, for me, in my practice, it made me learn and dig deep. But as far as, the Nigeria program as a whole, it's been a detriment.
Yeah, we shifted a lot of our focus on, again, web-based platforms, outreach that way. We did our annual exams in Kenya virtual with the faculty there on site also serving to do in person. So we have like a hybrid system at Kenya, which is kind of nice, which allows us some more flexibility than having to send people year round. But we are opening up again, and our first team is actually out in Kenya right now since the start of the pandemic. So from what I hear, everything's going well.
And I think here the important difference to highlight is that in Kenya, there are some IR faculty on the ground that were able to continue the program, right? So I think you guys didn't have the same pressure maybe to send teams early during the pandemic.
Yeah, exactly. So now we are shifting to send redeployments, and we'll get back to where we were before, but we could shift our focus to more web-based platforms because we had that flexibility in the way that Kenya program is designed. Yeah.
And Tariq, do you mind if I share my screen here quickly? Because I want to, on this topic, I wanted to show a little graph that I think sort of explains the whole
you
thing.
can share it right now.
Can you guys see this?
Yeah.
So this basically shows the correlation of visiting faculty per quarter and procedures performed per quarter in Tanzania. And you can see the impact of COVID, right? So we're starting here in the last quarter of 2018. You have, let's say here, about 2 faculty going per quarter in the beginning, or, it was probably a little more, maybe that's 3. And, a certain number of procedures per quarter, then, sort of starts slowly going up and up and up. And then here COVID starts, right, in the second quarter of 2020. So you have no people visiting for half a year. The procedure number really drops significantly, right? So this goes down to about 1/3 of what it was here. Slowly, it starts picking up again because, they were continuing to do cases. Eric, Azza, and Ivan, the senior trainees at the time, were starting to do more and more stuff by themselves. And then when we were able to resume trips here in the third and fourth quarter really of 2020 is when you start then the procedure numbers really going up significantly. And now this peaked in the third quarter of 2021, which is when Eric's class graduates. We have several faculty going during that time for the final training push, and then for their exams. And then now this is basically what we want to see, right? So we're seeing now the number of visiting faculty sort of going down, but the procedure numbers sort of continuing to go up, right? And that's what we want to see, is that we want to sort of reach a point of sustainability. And Eric and Azza are now the 2 first Tanzanian faculty, and their graduating colleague Ivan moved back to Rwanda, and they're now in a position where they can continue the program by themselves. We still have some funding now, so we're basically planning on continuing trips until the second class graduates this September. But even if there was some new variant next week and we had to stop trips, I would feel good, that the program's in good hands, and the patients there are going to continue to get the care they need.
Yeah, one other thing I would mention, during the pandemic, I think that was important, is to just, if travel did have to come to a halt, that we try to continue, our discussions with in-country stakeholders and keeping those relationships going, because we don't want to lose communication that way and then have to start over when we were able to send deployments again. So that was a big factor too, I think, just keeping everybody engaged still and trying to keep those relationships going well.
Yeah, hello. Yeah, can you hear me?
Yes.
Yes, we can.
Yeah. One thing I think, apart from the difficulty which was caused by COVID, but most of the institutes outside, they are doing also their training into like a video, like through Zooms. So I thank God that during COVID, we got opportunity to attend most of the lectures from different like universities, because we are being done through the Zoom and stuff like that. So that was a good part of the COVID stuff. And then, but it's also taught us some lessons that we have to push. We have to push and make sure that we have sustainable like IR service in Africa, because you can see during COVID, each country and each university were fighting among themselves. There are no like visiting doctors from one country going to save COVID people in another country, except in a few scenarios in Europe. And this was like a reminder to us that we have to strengthen our health system without depending on other countries. Thank you.
That's a really important point. I think there was sort of like countries got focused on their own issues first. So, and on that note, actually, one of the current trainees in Tanzania, one of the current junior trainees is actually was actually training in China at the time. So he was an IR trainee in China, and he got kicked out of the country when COVID started. So basically, with the start of COVID in China, all foreigners got kicked out and lost their training visas. So then he had to go back to Tanzania, and at the time we had just started the training program. So then he enrolled there. So it worked out well for him, and we're very happy to have him, because he had already been training in China for over 2 years in IR. So he's actually very experienced. So it was good for us, and worked out well for him. But what it shows you is that in times of hardship, it's difficult to rely on other countries.
Yeah, I saw that period of time, like we were at war. Really, everyone was basically on their own, and that was basically what it was, So that's why we all have to be self-sustaining going forward.
Exactly.
Good. That's some great insight. Thank you, guys. It's good to hear your perspective about how the impact has affected the global IR work in general, and to hear the challenges you faced, and also the innovative ideas that was built throughout this. So just moving on to the second question, could be related to the challenges that you faced. How do you propose to tackle the common funding limitations in the future and ensure like a sustainable global IR development going forward?
I think I'm going to go back to what I said earlier. Is we just have to kind of lean on the experience from India if we can, and what they've done, because it's a population of over I think it's 1 billion people in India, and they have very decent healthcare, which isn't very expensive, and very good healthcare, right? And in Nigeria, we spend a lot more money per capita on healthcare, and we still have very shitty healthcare, and those are just down to policies, So I think, we just have to, advocacy would be the key going forward into making sure that we formed this SAFIRE in Africa, but it's really not that functional. We really don't do much right now. We just need to talk more with SAFIRE, make sure that we're advocating within the health systems in our countries and the government, and seeing how we could push those type of policies that they have in India to work for us here in Africa.
Yeah, and I think it's going to be really important for countries to collaborate and sort of form a consortium and then negotiate, have like stronger negotiating power, right? Because like you're saying, in India, you have 1 billion people. In sub-Saharan Africa, you have 1 billion people, right? Or I mean, in India, you have slightly more. Is it like 1.5 billion now? I don't know. But either way, sub-Saharan Africa is over 1 billion people. So if countries there sort of, at least in terms of IR, started really working together and then, negotiating together, with these companies, I think that would, help bring prices down and, establish some standards, because, each country on their own just has less leverage.
Yeah, I think those are great points, and I have to agree with both of them. I think that's an important way to go forward, and I think the other way is, that's something else going to be important, is establishing that track record. So I think a lot of what they're doing and the groundwork they've set, just shedding good light on that and really focusing on what's worked, I think will also help move things forward.
Yeah, and then I'll just add. Sorry, go ahead.
The other thing I think we need, I think, to reshape the way we are advocating IR. It's very difficult, I think, to have funds in a whole setting of supporting IR. I can give you like an example. We have to narrow down and find a way how we can get support, either from the industrial perspective or from the World Health Organization perspective, into a disease-specific funding. For instance, we have a lot of hypertension in Tanzania, maybe due to psoriasis. Okay, so there are a lot of patients who they are being denied to have TIPS, simple procedure like bowels, biliary drainage. So I think let's start now focusing on disease funding projects instead of the entire big animal IR. So, okay, so that one, we can also make it easier to present into different industries. If you tell someone, I want you to fund me into IR, it's a little bit, a lot of explanations to him. But if you tell him that I have a lot of HCC patients are dying in Tanzania, because most of them are presenting at the health facilities in a stage in non-resectable, non-surgical patients, they're only depending on systemic chemotherapy. We want them to offer, to have tests or blind embo, or that's a kind of way of thinking I think we have to change on IR perspective so that people can have fund on that. Another issue is these big industries. They need now to open the third door. Africa is still being considered. I don't know how they consider it, but if you can see, there's a lot of population, a lot of diseases, but you can't find any, like Hamid was explaining, there's no industrial investments in Africa. So I think let's start now challenge, advocating IR into specific organization, which deal maybe with PPH into WHO. We can do uterine artery embo in a PPH, stuff like that. So that's where I think that's how we can get some funding instead of just saying, okay, let's find funding for IR. It's difficult. It's like saying, let's find funding for obstetric gynecology. Let's find funding for maybe pediatrics, other than to be a specific into disease perspective.
I agree with Eric on that. And what I would tell everyone though is that we're kind of already winning. Fabian, you know there's a company that we used to try to talk to for a long time to set our supplies. The company I'm talking about. Guess what? They're sending some representatives to Nigeria next month. Right.
That's awesome.
And why is that? We used to beg to talk to these companies, right? The only reason they're paying attention is they're starting to look at the numbers. Like, oh man, these guys are actually spending money on our products, and they're spending money to buy these products on US prices. What if we could do this, at a volume level, and start selling to them a little bit cheaper? So we're already winning in that they're starting to pay attention now. I mean, and we used to beg to talk to these guys. They paid us no attention before. So as I said, we just have to keep beating the drums. I know it's difficult, just keep doing the cases, keep showing that the cases are being done, spend as much money as possible to get the supplies when we can, and for every country too. And I made this point in Tanzania. I think we focus too much on, the big population that cannot afford our services, right? Let's focus on, making sure we only take care of the poor people. I think it's very, very important. And I said this to Eric when I was in Tanzania, that you caught enough those Tanzanian patients or those patients that are around Tanzania that could afford to go to the US, that could afford to go to India, and make sure that they come to Tanzania to get care and charge them appropriately, because they would have gone to the US to pay those sums anyways. And that's how you make sure you could take care of the poorer folks. Like, I just got a call from one of my colleagues this morning that's bringing a patient from a public hospital to me tomorrow to do a renal artery embolization. That patient has no money, but we're going to do the case. Why are we able to do the case? Because we could make sure that we're getting enough funds from the patients that could pay for those cases and the patients that would go to the US anyways, right? And those patients are still paying 30% of what they would pay in the US. So they're winning, we're winning, and everyone's winning. So I think, we just keep beating that drum, and they would keep noticing us, and it would eventually happen where they would come to us and say, you know what, how do we do this on a larger scale?
Yeah, I think that reiterates that idea of the track record. And I think what Ahmed's really talking about there is that medical tourism approach, right? Because a lot of that money is going over here to the US, and it's a lot that could be kept there to help build the programs there. So I think that's a very good approach, and I would definitely agree with the comments that he made.
Yeah. Before we started the program, like in Tanzania, as kids with like lymphatic malformations were being sent to India, and the government was paying like over $10,000 per trip over there, right? Because then they need like a medical transport, they need to pay the hospital in India, they need to pay the physicians there, etc. And now, it's being provided in Tanzania. So, we're basically saving the Tanzanian government hundreds of thousands of dollars. And just since we're on this topic, there was a question earlier. Robbie from Trinidad and Tobago was asking about Trinidad and Tobago, trying to set up a TIPS program there, and is unable to get Viators. So we have exactly the same issue in Tanzania, and I'm sure that Hamid has been dealing with this in Nigeria. So the problem is that Gore, I actually spoke sort of to their global marketing executive about exactly this question just a few weeks ago. And I told them, hey, how can you guys not sell this in Tanzania? It's like we've started doing tips there. And like right now what we're doing is that we're layering like a non-covered stent with a covered stent. We sort of just overlap them. But obviously having Viators would be a lot nicer. And what they're telling me is that they're basically not ready to supply Africa because they don't have sufficient stock. So they are basically trying to start selling Viators in China. And in order to do that, they need to have a stock of like 5,000 stents or whatever in order to supply the hospitals that they're working with there. They're saying that their margins are so slim in terms of production. I don't know about their money-making margins, but in terms of producing equipment, they are really, basically shipping out whatever they're producing, because these Viators are actually handmade somewhere in the US. So then I told them, hey, why don't you just open up a plant in Africa, start producing Viators there. Yeah, no, it's too complicated, too complex, not really an option right now. So, you can interpret that how you want it. But, at the end of the day, I think what Hamid said earlier is really true. Is like there needs to be production of IR equipment in Africa. That's really the only way. Shipping stuff from the US and relying on US companies isn't really a solution in the long term. So, Robbie, I don't know if that answered your questions, why they're not selling those in Trinidad and Tobago. It's simply because it's not their focus, and they don't have enough stents even to supply the countries where they're doing business right now.
And just to not that I want to defend the companies, but I also want to say that Africa is a very, very difficult place to do business, right? Nothing is straightforward. I could tell you, you try to go register a product to ship it in, you gotta bribe one person and bribe. There's just no straightforward, way to do things. So some of these companies like Medtronic, for example, has been in Nigeria for years now, trying to advocate to sell products here, and they've just been frustrated, because of the processes. There's just not simple. It's not like the US where, there's a form for you to register your product, everything's simple. Here, there's a backdoor route to everything, and someone's going to frustrate you at every level. So they also have their own frustrations. So I think we just need to find a way to kind of come together and work together. For for merit, we found a way to ship products to Nigeria, and we've been doing it now for about a year and a half. None of those products are registered here, but it's been working because we've done it in a semi-legal way. We've not broken any laws, and we're able to take care of patients. And now they're coming to the country to visit. And the next step is probably officially registering those products and making sure that we could do things a little bit more openly.
Awesome. That was a great discussion and a lot of creative strategies to ensure a sustainable global IR development. Moving on to one of our last questions. In your experience, how much external funding has been needed to set up global health sites, including the initial funds as well as the maintenance or ongoing needs? And also we touched on the topic of the trainees grants that are available. How much personal funding is needed for trainees to finance global health work, and should this be expected?
I can say a word. So basically, with once we got the RS&A grant, my goal was to allow medical students and IR trainees to go to Tanzania without paying anything, because I remember very well being a medical student and not really having much money lying around. And being annoyed that there's not really many opportunities to do global health stuff, without paying yourself. So I felt that was really important. And it's not that I expect medical students that go there to contribute much initially. And obviously they're not going there to train anyone because they can't, and because they don't have the knowledge. But the goal is more to get people interested in global health and to create some awareness, right? And then some of those people that go there are going to be the future leaders, right? So I mean, for instance, Tariq was in Tanzania now during his residency. Was it last year, Tariq? Right, I think last year, and so I think that's really important to sort of allow students these opportunities, and then in terms of how much funding is needed overall, I actually was just calculating now while we were talking. So in total now for the Tanzania program, we've spent exactly $180,000 over the course of 4 years. But then you basically have to think that 1 year wasn't really a proper year because of COVID. So that's 2020. So let's say like 180,000 really over 3 years. So it's about, to keep a program like this running, is about $60,000 per year. Okay, and from those 180,000, 75,000 came from RS&A, and the rest came, I would guess like almost like 40,000 came from Doximity, and the rest is like institutional funding, and like other, small grants. We had some grants from like the German Student Association and some other US-based grants. So it's basically a mix. But yeah, if you're really looking at starting IR in a country, you're looking at, if you want to bring teams there every month, you're looking at around $60,000 per year.
I think that's a good breakdown that Fabian gave you for like how their program started and how that works. I think to give a different perspective for our program, I think on the intending side, self-funding is kind of almost expected. We don't really have that many funding programs from the intending side. And then for the trainees, again, our big focus is on that partnership with SIR and the funding opportunity we have there that lends about $7,500 per year to trainee trips, which if you equate could be possibly like 3 trainees that we can sponsor a year. And then the rest of the funding has to come from institutional funding and the Doximity grant that he also mentioned. So I think the expectation should be there may be some self-funding going on, but we, as much as we can, we like to fund the trainees as possible.
Awesome. That's some very greatly beneficial thoughts and insights from everyone. As with any kind of conversation, we'll continue to talk about this moving forward. And hopefully we can expand the field of IR to make it available to everyone nationally and internationally. I think this is a great place to end our important discussion today. And if anyone has any questions or further topics relevant to the global health IR, that they would like to open for discussion in the Global IR Roundtable, or even join us as a panelist in the future, please feel free to share your thoughts and ideas with us in the email we provided in the Zoom chat box and with the survey available. Again, we really appreciate everyone for taking the time to join us in today's important and inspiring discussion. Just as a reminder, the webinar is recorded for everyone's benefit and for prosperity to our aspiring donors who should consider watching it in the future, and hopefully continues to be an inspiration to everyone. So as behalf of myself, Navreed, and the SIR-RFS International Outreach Committee, we would like to thank everyone for joining us today, and we will look forward to the upcoming Global IR Roundtable discussion. Have a great day, everyone. Thank you.
Thank you so much.
Thank you,
Thanks,
everyone.
Take care.
Take care.
Thank you.